homage to those of us who have had to manage dementia in our own families. It was World Alzheimer's Day this week, and that means I have some new data to share. And I hope that the takeaway from this will be that Alzheimer's isn't always Alzheimer's, dementia isn't always dementia, and there's a lot of overlap with vascular disease. And this is not going to be an intense survey of all types of dementia workup and treatment. It's an overview of some other components of dementia. So just to start, intelligent behavior is the aggregate or global capacity of the individual to act purposefully, to think rationally, and to deal effectively with his or her environment, which obviously makes me not qualify, as of my recent demonstration, to have intelligent behavior. The opposite of that would be dementia, and dementia has been described since the 1500s, but was in the 1800s determined to be two different groups of madness or insanity, which was the failure of the mind in old age versus schizophrenia or precocious dementia, which is more psychiatric disease. So we've become more clear on what those things are. All over the internet, you can find nice charts like this that show how much dementia is Alzheimer's and how much it's all these other different things. And with these ranges, there's a lot of overlap, and that's why there's all these nice different colors. But a recent publication to describe that better is that an autopsy study of 447 patients who had been diagnosed with Alzheimer's disease. 82% had some Alzheimer's, but another cause. 15% had no Alzheimer's disease pathology at all, and only 3% were only Alzheimer's. So if there's nothing else that you take home from this, is that Alzheimer's isn't always Alzheimer's. And we use that term, many people use that term to indicate all sorts of dementia, which probably isn't accurate and really makes a big difference in how to treat and what to do about these patients. This is the chart that came out of this last week, Alzheimer's Day. And this looks really scary because the projected number of people aged 65 and older in the US with Alzheimer's dementia is supposed to more than double in the next 40 years, which sounds really scary. But there's a couple of issues with this. One is what I just said, is that Alzheimer's is not always Alzheimer's. So we don't really know what this means. But the biggest projection of this is because of the aging population. So if you simply have more old people, you're going to have more total old people with dementia. But the overall dementia rates, which is per capita, are actually declining, though the Alzheimer's rates are staying steady, which means that we are getting better at preventing the non-Alzheimer's kinds of dementia and have yet to even touch being able to prevent true Alzheimer's disease. So let's think for a minute, how do we determine what dementia is? It is a cognitive decline, so it has to be a change from baseline in usually at least 2 cognitive domains, but it can be 1 if it's bad enough. And I'm going to talk about cognitive domains in a minute. It can't be explained by another problem like drug intoxication or chronic drug use, depression, psychiatric disease, and it has to be severe enough to interfere with function. And I put function in gray because there's no good definition of that. So is interfering with function enough that maybe you can't balance a checkbook anymore, but you can do all your other things? Or is it so bad that you get lost in your own house? So the different people's definition of interfering with function is variable, and so there's not a good definition of it. And there's insufficient diagnostic criteria for dementia, that there is no standard for screening. So we get our mammograms and our colonoscopies and our screening for blood sugar and blood pressure, but there is no national standard for screening for dementia. The standard is simply a primary care doctor is supposed to ask if there's any cognitive problems, and that's the limitation, or that's the extent of our standard of screening. And then another word you'll hear in talking about dementia is mild cognitive impairment, or MCI, which has very similar criteria with relative preservation of function. And again, what does that mean? and absence of dementia. Oh, well, thank you. That's a very helpful definition, right? So what is there's a lot of gray areas between what's normal, what's mildly abnormal, and what criteria when you actually hit dementia. So let me talk for a moment about cognitive domains. You have to lose at least one of these, and usually two of these, to qualify for MCI or dementia. And there are quite a few of these cognitive domains that they're listed. I'm not going to go through each one of them. That would be a whole talk in itself. But even simply memory is actually many different things. So for example, episodic or recall memory is, what did I have for breakfast? What happened in my life, in an episode of my life, right? Procedural memory was remembering how to brush your teeth, how to do a procedure, and on, all these different kinds of memory. Executive function is problem solving, completing tasks, all those sorts of things, recognizing insight of your disability, for example. So there's many different cognitive domains, but what does that mean when we're actually looking at a patient? So this is a standard kind of thing you can pull off the internet to educate patients about dementia, the signs and symptoms. I've listed some other here that are related: getting lost in familiar surroundings, difficulty completing tasks or planning tasks that you used to be able to do all the time. My grandmother, for example, who passed away from dementia at the age of 93, our first sign that there was something going wrong is she had played bridge every day of her life possible for as long as we could remember. When she was about 89, all of a sudden she didn't want to play anymore, and it turned out that she couldn't coordinate in her mind how to play and how to win, because she used to beat everybody. So a change from usual activities is an early sign of that. So trying to assess, to monitor and track people's dementia has been a challenge, and I'm going to share just 3 tools that are commonly used in looking at that. When somebody comes in with a complaint of memory problems or functional problems, we try to assess that and enumerate it in some way so we can track it. This is the mini mental status exam, which was first published in 1975. And I'm not going to go through it in gory detail because it's not in use much anymore, because they've decided they need to charge for its use, which is kind of silly because it's not a very good tool, to be honest. So it was okay at screening for classic Alzheimer's because it's focused on memory and language sorts of tasks, but it really is light on other kind of cognitive domains, and has no executive function except for can you trace this, which is also a visual spatial, so it doesn't really distinguish the different kinds of cognitive function. The MoCA is one that's much more commonly used these days. This is the Montreal Cognitive Assessment. I like it. The speech paths use it a lot. It's got a good executive function. This is called trails, where you alternate connecting the dots between a number and a letter. So you go 1, A, 2, B, 3, C, and they have to keep track of that. And then drawing a clock is a really sensitive marker, which is a great tool. Naming things, attention, some maths, all different things on there. It's actually more sensitive than the mini mental status exam when compared head to head with patients with MCI or dementia. So that's why we like it. It's easy to use. They don't charge us to use it, and it's a little bit better at picking up problems. And then the other really commonly used one is the SLUMS, or St. Louis University Mental Status Exam. That again has more than, it has a little bit of language, but a lot of the other things: attention, calculation, fluency, recall. And it again is more sensitive than the traditional mini mental status. One of the advantages of this one is it's available online in over 20 different languages. Oh, and I didn't say about the MoCA that there's actually different versions of the MoCA, so that you can do them sequentially. So you can do one every year, and they'll have different tasks each time, but a similar kind of scoring. So they won't memorize the answers and get it right, do better the next time. So anyway, so these are the screening tools we use, and then there's much more advanced neuropsych testing if there's any question that somebody has dementia. The strengths and weaknesses of these tests, the strengths are they're quick and easy to use. The weaknesses are they don't measure subtle deficits. They're dependent on your level of education, and there's cultural concerns about them. So for example, if somebody's never been exposed to lions and rhinoceroses, they might not do well on it. And then accessibility, because it of course requires vision, it requires people being able to draw and write things, those sorts of things, so may limit the cognitive evaluation. And then sometimes in clinic, the screening tool that you use doesn't match up with the history that the family is providing. Sometimes the history of their function is better than the tool. Sometimes the tool measures better than the history that you're given. The cases that the history sounds better than the tool shows is if they're having an acute confusional state, which is not the same as dementia, that would be a delirium. If they had baseline low intelligence or low education, that would just be their normal. And so remember, the definition of dementia is a deterioration. And so if somebody starts with a low level, then it's not a deterioration. And then there are people that, maybe the family isn't very good at recognizing that they're not doing as well as they think they are because they're compensating for them. So inadequate recognition of historical problems by the family can make that, the history, make them seem better than the tool is showing. And then the tool can be better in the history in cases of mild dementia. People who started out highly intelligent or highly educated are not going to score on the tool, but they may be not doing as well as their normal. It's a decline for them, but not enough to score. The tool can look better than the history if they're not functioning well just because of depression, and rarely misrepresentation, where the family is hoping to benefit from getting a diagnosis of dementia to get services and that sorts of things. All right, so that's kind of the short version of how things are screened in a clinic setting. Let's move on to just a couple of slides on Alzheimer's, because that's what our kind of standard thought of dementia is. It was described in the 1970s by a family whose the wife developed dementia and Alzheimer's was her husband. The classic sign of Alzheimer's is memory impairment, specifically of declarative episodic memory, which is being able to say what you just did. So short-term, not being able to remember what you've been doing, more than remembering old facts and those sorts of things. The next thing to show up is often executive function problems, and then the other kind of cognitive decline, cognitive areas decline later. And it is slowly progressive over time. And there is no standard for diagnosis. The only way to prove that someone had true Alzheimer's disease is by autopsy. We don't actually do brain biopsies to diagnose dementia. So this is just a graphic of Alzheimer's disease. So this is a normal brain, nice, happy, fat neurons. Over here, we have neurofibrillary tangles. The neurofibrils are basically the skeleton of the neurons, and so they get all tangled and start decaying, start breaking down the shape and pattern of the neurons. And then between the neurons gets deposition of this beta amyloid chemical plaque that I'm going to talk more about later. But these are the classic findings on an Alzheimer's autopsy brain. So moving on. So the traditional risk factors that are described in the literature for Alzheimer's are things like high fasting insulin with or without diabetes, hypertension, LDL, low activity exercise. Those sound really familiar to what you've been listening to all day, right? That's the question I want to think about as we go through talking about these other kinds of dementia in a minute. So I'm going to shift to vascular dementia, which also has the diagnosis definition hasn't been updated in quite a while, 1993, you see. They have to meet criteria for dementia or MCI. They have to have proven cerebrovascular disease. There's supposed to be a relationship between the two, that the dementia starts after the stroke within a couple of months at most. And classically, it's described as a deficit in elaborate attention and frontal executive function, which means basically processing speed. So people with vascular dementia traditionally were thought to be able to do things, but just be really slow at them. And so I'm going to maybe dispel that myth the next few slides. So real quick, memorize these because we're going to go through cases because that's more fun. So got a 70-year-old lady who hadn't seen her daughter since before pandemic and has been really isolated all that time. Before that, she was occasionally forgetful. She'd forget her keys and occasionally, forget what she was at the grocery store for and that sort of thing, but didn't think that much about it. It was not affecting her function overall. But today, after her daughter called and reminded her that she was coming tomorrow, she forgot to pick her daughter up at the airport, even though she was super excited. And then the daughter gets to the house and her cooking's not up to her usual. She usually made homemade soup, and now she's opening a can of Campbell's. The house is a little bit messier than usual. It used to be meticulously clean, and the car had some dents and the patient couldn't explain. So the daughter brings her to the hospital, to the emergency room. So during their evaluation, OTs did a slums. She got a 17 out of 30. Oh, I forgot to talk about the scoring on those tests. So all of the other tests, all the MOCA, the slums, the mini-mental, are 30-point tests. And usually above 27 is considered normal, 21 to 26 is considered MCI, and below 20 or below is considered dementia. So the 17 qualifies as dementia. She did poorly on memory. She did poorly on word generation and fluency. She had decreased orientation. She couldn't remember what day it was, that sort of thing. Got distracted easily, but was okay on visual, spatial, and naming tasks. And this isn't her scan because this is a nice progressive scan that I pulled off the internet of MRIs. And this is the one scan that we're going to see this direction. So this is as if we're looking towards their face. So it's an AP projection. So the things I want to point out on there, she's got nice, beautiful white matter. White matter is totally normal. Her cortex, this isn't a normal patient. Cortex is thick and happy. The corpus callosum, which is the connection, the white matter tract band between the two hemispheres, is nice and thick. And this arrow is pointing at the hippocampus, which is juicy and fat and beautiful right there. And then as Alzheimer's, because that's what this lady had, progresses, the cortex gets thinner, so the spinal fluid space around it gets bigger. The corpus callosum thins, and the hippocampus starts to shrivel. And way over here on a true Alzheimer's, you've gotten so much thinning that you've ended up with great big ventricles because the tissue is shrinking and leaves space for more spinal fluid. And she has this little nubbin of hippocampus that's atrophied disproportionately to the rest of the cortex. So her diagnosis is probably Alzheimer's. Can't prove it without a biopsy or an autopsy, but she doesn't have any vascular disease on there. And her history is classic for it. A little bit forgetful early on, and now her memory is the primary deficit. So moving on to another case, I got a 56-year-old, so very young. This is a patient who was admitted to the hospital for an acute GI bleed on an anticoagulant, had GI AVMs presented, besides obviously he was hypotensive, he was confused, delirious. He was unkempt, and they resuscitated him, got him blood, got him better, but he was still, quote, confused. And so they had a neuroconsult. He had had previous strokes, but just seemed more confused than they had expected. A MOCA was performed on him, got a 15 out of 30, so qualified for dementia. He did very poorly on visual spatial tasks, did very poorly on word generation and fluency. Attention was decreased, memory was fine, orientation was fine, naming was fine. He could hold a normal sounding conversation. So very different profile than the previous lady who was missing these things but did okay on these, right? So a very different patient. Here is his scan. So we have here an old left frontal stroke, and these were all old strokes that were known. So an old left frontal stroke, so that's where he's having a little bit of word recall problems, frontal lobe executive function, and bilateral parietal lobe visual spatial problems. So he's got more than two cognitive areas of deficit with a normal looking brain in between those specific infarcts. So this is multi-infarct dementia. So about 10% of people develop, quote, dementia after a first stroke, about 33% after a second stroke will technically develop some level of dementia because, especially if they're cortical strokes, because you're taking out different brain functions. So moving on. Now I have KS, who's 67 years old, works with a librarian with no issues. So, you know, can manage the Dewey Decimal System and do all the computer stuff, unlike me, that a librarian has to be able to do. And she's been fine. And then yesterday morning, she woke up and was really confused and couldn't remember what was happening, couldn't remember what she was supposed to be doing, really, really out of it. Came to the hospital. They did a slums, among other things. And she did very poorly on immediate recall and word generation and fluency, which sounds a lot like the dementia lady. I mean, the Alzheimer's lady, right? Everything else was normal, except that these two parameters. So it really sounds like that Alzheimer's lady, but it happened overnight, which is very different from Alzheimer's. And this was a really, really fluky stroke. So these two little tiny white dots are strokes in her bilateral fornices, F-O-R-N-I-X, which is a little tiny band of tissue that's the outflow tract from the hippocampus. So remember, in the Alzheimer patients, the hippocampus atrophies. So she suddenly disconnected her hippocampus from the rest of her brain and was unable to make new memories with this stroke, which is just an oddball thing. So she did have hypertension and hyperlipidemia. So those are her stroke risk factors. The fluke was that her anatomy, her vascular anatomy, both of these areas were supplied by the same artery that divided, instead of usually it's different arteries, one on each side. And this is her FLAIR image that shows she's had a little bit of microvascular disease, but not too bad. But really, this is what caused her acute dementia. So her diagnosis is called strategic single infarct dementia, meaning a single stroke in a critical spot that caused dementia. So there's a couple of spots. There's only a couple of spots in the brain that can do that. And that one was the first time I'd ever heard of a fornix infarct. That was Dr. McLenithan's patient. So in looking up causes of strategic single infarct dementia, there aren't many, but I found a series of 12 cases. And of those 12, 11 of the strokes were in the left brain, which is fascinating, but language is a really big part of cognition, so that's probably why. 8 of them, and so this is the left brain on the inside, the left brain on the outside, a focus on the left brain. 8 of the 12 cases, so 3/4 of them, included the thalamus, plus or minus another region. And the thalamus is the area of the brain that everything goes through, coming in and going out. And especially the anterior thalamus that projects up to that frontal lobe where all the executive function happens. So the anterior thalamus specifically is the most likely culprit. There's an area called the angular gyrus. So this is a cortical area that sits right in here. And this is right next to the visual cortex back here. And the Wernicke's are receptive, the receptive language area in here. And the parietal visual spatial areas. So a stroke right there can cause trouble making memory, or making, let me say the right thing, interpreting meaning from visual words. So you can see the words because the cortex back here is okay, and you can turn them into words in the receptive area of speech, but you can't figure out what it actually means. So being able to read the words doesn't mean you understand what the words are. And there's also some visual spatial mathematical geometric kind of problems in there. So there's they happen in that same area. So they have problems with number processing, language processing, enough things to qualify for dementia. So I just think that's nerdy anatomy and really fascinating. The next place that can cause a single strategic infarct, stroke, or dementia is the basal forebrain, which is this little area right in here, and it's a little small area right above the eye socket, and it is the source of the vast majority of the acetylcholine neurons in the brain, and acetylcholine is highly indicated in Alzheimer's dementia. So Alzheimer's is a loss of diffuse neurons that are cholinergic, but this is the highest concentration of cholinergic neurons, and knocking that out can make you have an acute dementia that looks all the world like a Alzheimer's disease, but it just happens overnight. And that's very close on that MRI. The fornix is right in there. And then medial frontal lobe and the corpus callosum. So it's the executive function area, but also where that information crosses over to the other side. So you can't compensate. So you lose the ability to make good choices, to solve problems and all that sort of thing. And then one single case was just isolated to the anterior corpus callosum, again, connecting those bilateral frontal lobes from each other. So pretty interesting, very rare. Interesting to a nerd like me. Next patient is a 70-year-old who comes into the ED with a gait imbalance, dysphagia, dysarthria, has a history of Alzheimer's, is on all the expensive drugs, and hypertension. His slums was a 19. He did poorly in executive and visual spatial function, decreased memory, and intact orientation and naming. And again, this doesn't quite fit that pattern we saw in the first patient who had classic Alzheimer's pattern. And so got to question the cause of his dementia. And indeed, here we go. So here's the stroke that causes his current symptoms, his gait imbalance and dysphagia. But here's his MRI that, unlike the Alzheimer's patient, does not have normal white matter. He's got confluent small vessel white matter disease throughout all of this area. And normal cortex, if I looked at the rest of the scan, there were no cortical strokes, just these little tiny guys. And then over here is a swan image, which actually shows any previous hemorrhage of any age. And he has no hemorrhage in here, so that's good. So he's got this white matter disease that I changed the cause of his dementia on his chart from Alzheimer's to subcortical dementia from hypertensive arteriopathy. And that's a mouthful, but here's what it looks like pathologically. There is a picture right here of a normal arteriole, which are smaller than arteries. They're the little teeny branches before they become capillaries. And these are metabolically active. There's muscle cells in here. This is a nice healthy thickness. Here's the red blood cells flowing through. These are autopsy slides, so you don't actually see the blood cells in them, but this is, as hypertension can cause, basically the simplified version is scarring of the arteries, and they get thick. So see, this is the thickness of the artery here, how this artery wall is getting thicker. This is kind of a tangential cut, but the artery wall is thicker, and these are like worse and worse and worse examples. So here is actually the lumen of this artery. You can see how thick that is. And as it scars, it gets little fat globules in there, and it can get really nasty looking like this. It's all this just scar tissue built up. You can see how big the artery was supposed to be out in that wall and how little flow there is now. And then this is a really severe case where there's just these little tiny channels of blood flow through there, and the artery is almost obliterated. And so you can see why that would cause decreased blood flow to parts of the brain, and that's what small vessel disease is. Pathologically, it's a little bit more complicated than that, but this is the cause of the problem. So fibrinoid necrosis is what they call this pathologic finding, but this is what, when you hear us talk about small vessel disease, it's that. And these little things cut off, they're so small that patients are rarely clinically symptomatic. So that guy that I just showed you had never actually had a clinical stroke until this one hit a critical spot. But he had had plenty of previous damage from hypertensive arteriopathy. All right, now we've got a 56-year-old, this was just a few weeks ago also, admitted for COVID, and while she was there, an RRT was called for transient left-sided weakness. And she had a history of poorly controlled hypertension and had recently been hospitalized for a right basal ganglia hemorrhage. So we were worked her up for seizure and everything else to make sure that that wasn't what caused her transient symptoms. Sent her for an MRI, which I'm going to show you in a second. Unfortunately, because her acuity with her COVID, we didn't get cognitive testing before she got signed off the neuro service. She did get to go home eventually, or but we'll get cognitive testing when she comes back because I'm going to be really interested. Because just talking to her, she seemed totally coherent, able to tell me a story, didn't come across as having any sort of cognitive problems. But here's her scan. So here's a little acute stroke that caused her transient symptoms. Here's her chronic white matter disease, similar to the other guy, not as bad as the previous guy. Here's her big hemorrhage on that gradient echo. That's the hemorrhage that she had had a couple of weeks ago. But every single one of these little black spots are microhemorrhages. So she's had, too many to count, little tiny hemorrhages throughout her brain, probably over the entire time she's had hypertension. So she has really severe hypertensive arteriopathy. And my talking to her is not the same as doing one of those screening tests, but basically, just from experience, I would suspect that she might have scored maybe a 26 or 27 on the slums. But I'm going to be really interested to see what she has in the future. So the same disease process as the previous guy, just much more severe because she had really horribly controlled blood pressure, and the fact that you can have that much hemorrhagic damage without having clinical problems is just amazing to me. Fascinating to me because I'm a nerd. Okay, next case is an 86-year-old with no cognitive history, presents with a left hemiplegia. She's been diabetic, diet controlled, and then non-insulin dependent for 6 years, but really pretty darn healthy. Because she wanted to go home when her hemiplegia was better, we were concerned after we saw her scan, which I'll show you. We did a MOCA. She got a 27 out of 30, which is considered normal. She had poor visual spatial problems, but all of her other cognitive functions were intact. And here's her MRI. This is the hemorrhage that brought her in. She actually did remarkably well despite that. And this totally explains her visual spatial problem because the visual pathways come through there. But the thing that was interesting on her scan was these little black dots up here. And you see she doesn't have any down deep like the previous patient that had all the little microhemorrhages. So she's got some, and there's more the higher we go up. And then there's also, this is a little subarachnoid hemorrhage. And they're chronic. These are old. They didn't show up on CT at all. But this is a different animal. This is cerebral amyloid angiopathy, or CAA, because that's easier to say. And here's some more pathology. Here's a normal. This is the same beta amyloid that we talked about in the Alzheimer's plaques, but it's a different location. It's actually distributed in the arterial walls. So this guy starts getting filled up with this beta amyloid protein. And what happens is it just makes the arteries brittle and they ooze. They crack for some reason. And so we get these little oozing microhemorrhages. They're rarely significant hemorrhages, but occasionally they'll have a big one like the one she had. But more often you see just these diffuse small little hemorrhages like she had on that scan. So it's that beta amyloid again. And the difference in beta amyloid, CAA, and Alzheimer's disease is where it's deposited. So the CAA, it's in arterioles instead of in the brain tissue itself. In pathologies or autopsy samples, 26% of people with Alzheimer's proven had CAA, but only 25% of CAA patients also have dementia. So CAA can be in people without dementia and can be in people with Alzheimer's proven. Patients with both Alzheimer's pathology and CAA deteriorate faster than either one alone. So it's an interesting thing, and why it goes different places, we don't know. So these look the same, right? The hypertensive one had microhemorrhages and big hemorrhages. The CAA also had the same thing. The difference is that the hypertensive angiopathy is more likely to have the microvascular ischemia or the white matter disease, but less than 40% of CAA patients have microvascular ischemia. Hypertensive are more likely to have their hemorrhages and microhemorrhages be in the deep structures, in the basal ganglia, the pons, thalamus, as opposed to the superficial lobar hemorrhages like the other lady had. But the microhemorrhages, not usually as diffuse. That one scan that had them everywhere, that was the hypertensive one. And these are a little bit more scattered. These guys are associated with that convexity subarachnoid hemorrhages. They can have dementia with no ICH. They can have ICH with no dementia. So they can, a bad case of either can be really tricky to know which you're looking at, but usually if it's really bad, it's usually the hypertensive kind. All right, moving on to my last one, my last case. I got a 46-year-old guy, so very young, transient, so a TIA, first ever TIA, has had migraine since he was 20. Mother had migraine, stroke, and early onset dementia. He is a marathoner, super healthy, no recreational drug use. Here's his scan. And we all went, wow. And the reason we had gotten the scan is because it was the first time he'd had a TIA. And this is a lot of damage for a healthy 46-year-old, right? That does not look right. So we went, wow, we need to do a stroke workup on you. So we did the whole stroke workup, the stroke workup in young. So we got all the basics. The blood pressure is great, no diabetes, LDL's fine, normal vessels, normal telemetry, normal echo, hypercoag panel, normal slums. So no cognitive problems at 30 out of 30. So what we then had to do was ask him if he wanted genetic testing, because we were suspicious of a problem with his Notch3 protein. This is a receptor protein on smooth muscle cells that is important to keep the arteries healthy, basically. So if it is an alteration in that gene, it impairs the normal function of the vascular muscles, and they kind of necrose and die off. And so they end up looking kind of like that fibrinoid hyalinosis on the hypertensive, just a different process causing that problem. And the reason I said genetic test in question mark is because you don't go into that with your eyes closed, because it's not 100% predictive, but it's highly suggestive that you will develop early onset dementia. So you have to think about what are the pros and cons of knowing that information. And so somebody who's 46 maybe have a 20-year-old kid who may be thinking about having kids of their own. And the reason we care about this is an autosomal dominant arteriopathy, which guarantees if he has this, that his kids will have it and can cause early dementia. So it's something that is a classic presentation, can become dementia early on. And unfortunately, there's nothing you can do about it except trying to protect them from other vascular risk factors. So that's my cases. Now, why do we care about all those different kinds of diagnoses? And I think it's important because remember, one of those cases, the guy had been diagnosed with Alzheimer's and his vascular risk factors had not been adjusted, and it turned out he actually had probably vascular cause of his dementia. So it's important to get the correct diagnosis, and referral to a cognitive specialist may help, or definitely getting imaging and acting on that imaging. So it will lead to a more appropriate workup and hopefully some treatment that may delay progression. Counseling is really important because if it's a vascular cause, we may be able to slow the progression. However, if it's just Alzheimer's, we won't be able to slow the progression. So these are important things for people to kind of plan their future. And then another really important thing is thinking about referral to clinical trials. There is a bajillion-dollar industry in trying to find ways to prevent dementia or at least treat it. But if we are using drugs that are supposed to help the acetylcholine system in Alzheimer's and we're just treating people with vascular dementia, then we're not going to get the clinical trial patients in the right place that we need. Let me say that more clearly. If we want to try a drug that's supposed to help prevent progression of Alzheimer's, but you put a vascular person in that trial, you're not going to get the result that you're looking for. So we may be not getting clean studies to find drugs that are going to be effective in certain things. So the limitations are there's up to 82% overlap in vascular dementia and Alzheimer's, but proving that there's some Alzheimer's component may help you with those clinical trial issues and the right medications, but also recognize that there's a vascular component and you may be able to slow the progression. By the time people are diagnosed with dementia, the prevention is too late because there is nothing that we have found that reverses dementia. Treatment's only proven for mild disease. It may slow the progression. It doesn't actually make them better. And just an example related to this is this great study called the Atherosclerotic Risk in Communities that is 16,000 patients that were enrolled in 1987 with their median enrollment age of 57. And it is ongoing, and there have been a ton of papers published, over 180 papers published on this cohort, because they measured baseline vascular risk and they're looking at cancer, they're looking at heart disease, they're looking at stroke. And then this study they looked at in 2013, published in 17, about 10% of the population had developed dementia. And the people most likely were Black, they were older at enrollment into the study, they had a lower education, and they were positive for the ApoE4. And this is apolipoprotein, big word. It's a protein that carries different lipids back and forth between different cell types in the brain. And if they happen to have one copy of this bad version, number 4, they are 4 times more likely to develop dementia than if they have the normal allele. If they have 2 copies of this nasty one, they are 15 times more likely to develop dementia. But it wasn't clear vascular or Alzheimer's. They develop both. But really interesting is the hazard ratio for midlife. If the patients who had developed dementia versus the ones who had not, they were 40% more likely to have been smoking in midlife. They were 77% more likely to have had diabetes in midlife. They were almost 40% more likely to have been hypertensive. So again, these sound really familiar to risk factors for vascular disease. So it's really hard to sort out if they actually have any impact on Alzheimer's. So comparing Alzheimer's to vascular dementia, the incidence increases over 60. Midlife vascular risk factors impact both. They're genetic in some cases. So again, can you really tell the difference? And does determining that diagnosis make a difference? And I would say, again, yes, it probably does, because our treatments right now is supportive, preventive. There is nothing that really prevents them. We know that exercise may improve function and slow progression. Once you've got a dementia diagnosis, you've got it, and it's not going to go away. But the other things that once people have developed dementia, better control of blood pressure, better control of diabetes has not been shown to improve or slow their progress. Here are the drugs that are approved for Alzheimer's dementia. They are not cheap. And the studies didn't show great improvement or great stabilization. They showed slight slowing in progression. And tested in other kinds of dementia, they really didn't seem to help much. There's a billion-dollar industry in trying to prevent Alzheimer's, but again, none of these things, these diets, these drugs, have been proven to help, except for increased physical activity before you develop it, blood pressure control, cognitive training. So the more you use it, less likely you are to lose it. Can't talk. So wouldn't it be nice if there was a way to confirm Alzheimer's versus other types of dementia early, because there may be other things to do for them. So there may be in the future. So this is a PET scan. A SPECT scan would look similar. PET looks at tissue metabolism. SPECT looks at tissue blood flow. And bright yellow, the redder the color, the more active the brain tissue. So yellow is normal, and then this is really active for whatever reason at that moment. And Alzheimer's has a fairly specific loss of brain function over fairly specific brain areas. However, if you remember my patient with the multi-infarct dementia, he happened to have a stroke right here and a stroke right here, so his scan would look the same. So this is a person who had a normal MRI, and so we know that this is an Alzheimer's pattern as opposed to a multi-infarct pattern. But again, it's not super specific. It's sensitive for brain function. It doesn't tell you exactly why it's not working. So there's a new kid in town, which is a tracer that attaches to the amyloid. And so it's an amyloid PET scanning. These are FDA approved. And the only thing they're FDA approved for is ruling out Alzheimer's, because Alzheimer's is a clinical diagnosis of cognitive problems. So a normal patient with normal cognitive function has no amyloid, but this is a normal patient that has amyloid, probably amyloid angiopathy, but doesn't have dementia. So you can have positive that looks all the world like an Alzheimer's positive. So the study can only rule it out. It can't say that you have dementia or not, right? So only your clinical exam can tell you if you have dementia or not. And it doesn't predict the severity or the progression of the dementia. So is it any good if we have clinical criteria? Well, maybe. This is a study that was just published in the past year, I believe. I think it was 2019, late 2019. The question was, does amyloid PET imaging change doctors' decisions? They enrolled 11,000 plus patients with mild cognitive impairment, so MCI, and they looked with, they just did a one-time amyloid PET scan to see if that would change the doctor's care of the patients. In more than 60% of the cases, the scans caused the doctors to change their medical management. They were 2 times as likely to prescribe 80 drugs for MCI if scans showed significant amyloid plaques. So previously, the recommendation for starting those drugs like Aricept is that you have mild to moderate dementia. Mild cognitive impairment does not qualify as mild to moderate dementia. So this may actually be able to impact the care of people with classic Alzheimer's if they catch them early enough. And they also discontinued those expensive drugs with potential cognitive side effects when there wasn't amyloid present. So more than 60% of cases, they change it. So it may be something that can become useful. And so remains to be seen if that will become a guideline or not, but especially in cases that are mixed, it may help guide us to treat them, because I don't usually put a vascular dementia person on Aricept, but if I can prove that they also have an Alzheimer's component, maybe I will. So that's something that may change my care. And then the very last thing that I just have to mention, because you may have heard about it in the news, and I'm not even going to try to say that word or either of those words, but this is the new drug that was FDA approved for Alzheimer's in June of this year, and it has been incredibly controversial. It was controversial enough that the study panel that presented the data to the FDA resigned in conflict, in contempt. They resigned in protest from the committee because they did not agree with the FDA's decision to approve this drug. And these were heavy hitters. These were people from Harvard and Mayo Clinic that said, we don't agree with you. So here's the thing. They did those amyloid PET scans and proved that they had amyloid, and then they gave them this drug. And after a couple of years, they did another PET scan and proved that it cleared the amyloid, or at least decreased it. But they also found there was no clinical effect. It didn't actually change the patient's cognition. And they were all started, it was only in people with mild cognitive impairment. And some of those patients continued to progress, but they certainly didn't slow down. There was no clinical impact of clearing the beta amyloid. So it's not clear that maybe that beta amyloid is a side effect of the disease and not the cause of the disease. We don't know what that means. They excluded patients that were at high risk of having vascular cause, but the other thing, besides the fact that it didn't help the patients, was the cost. So the screening PET scan to decide to get it is about a $6,000 test. They required MRI monitoring every quarter. So 4 times a year, they had to pay $5,000 for an MRI. So that's another $20,000. The reason they had to do that was because over a third of the patients were developing edema or brain hemorrhage. Hello, that's a problem. And so we're up to $26,000 a year. Infusion costs, I don't know how much it costs to go into an infusion center. That's a once a month infusion. The drug cost is $56,000 a year. So we're talking about $76,000 a year for the treatment with no clinical benefit, and it's approved. So people are with dementia are clamoring to get this drug, but many large health systems, including Blue Cross Blue Shield and large health systems across the country, say they just will not give it. They're not going to pay for it, and they're not going to support this because they just don't think that there's any benefit for that cost. So I am done. Uh-oh. And my take home is that Alzheimer's isn't always Alzheimer's, and we should always be looking for potential vascular underlying causes that may be making people's dementia worse. Healthy lifestyle and aggressive vascular risk factor management early in life is the best prevention for developing dementia. And better specific treatments may be coming, but we need better diagnostic tests to make sure that we're treating the right thing. That's what I got.
It was great, Lisa. Thank you. So much information.
Once it got going.